Everyone, welcome to this lecture on cardiorespiratory physiotherapy practice, brought to you by FutureStep Physios. Today, we will be specifically focusing on abdominal surgery. In particular, we are going to discuss the types of abdominal surgeries a patient may have received prior to you seeing them, the pathophysiology of lung complications following surgery, cardiorespiratory problems in post-abdominal surgical patients, post-operative complications or PPCs, patients who are at risk for developing a PPC, available physiotherapy treatment options, and the pathophysiology of different treatments. So now I'm going to briefly mention a few different types of abdominal surgeries, in particular the types of surgeries which your patients may have had before you seeing them. A Whipple's procedure is a larger and more extensive surgery, which is most commonly completed as open cut given its complexity, rather than a minimally invasive approach or laparoscopy. However, both of these can be used, and this is completely dependent on how the patient presents and the choice of the surgeon. It's important for us to know this as physiotherapists, given that both the type of the surgery and the surgical length can increase or decrease the chance of a patient attaining a PPC, which we'll discuss in later slides. The surgery includes the removal of the head of the pancreas, duodenum, gallbladder, and bile duct, with a reattachment of the pancreas to the stomach and the stomach to the duodenum. The surgery is indicated for either malignant or benign tumours of the pancreas, the distal common bile duct, and the duodenum. In much rarer cases, the surgery will be done for trauma of the pancreatic head or duodenum. This is important for us to know as well, given that the presence of cancer can also increase the PPC risk, as we'll discuss in later slides. Hemicolectomies involve the removal of a certain part of the large intestine. For example, this could be the ascending, transverse, or descending colons, and it's indicated for colon or colorectal cancers. In some instances, there is also the removal of the surrounding lymph nodes. The surgery itself can be also used in other circumstances, for example in Crohn's disease. Again, both laparoscopy or open cut incisions may be used. However, when searching through the literature, it seems that a laparoscopic approach is discussed more so when compared to a Whipple's procedure. This may be because a laparoscopic approach is more simple compared to a Whipple's procedure, which is a larger operation. Again, as physiotherapists, we must appreciate whether the surgery was performed as an open cut or through a laparoscopic surgery, given that a laparoscopic surgery typically has a smaller incision site, shorter hospital stay, a faster recovery, and patients have a reduced chance of attaining a PPC. One more surgical approach that we'll discuss briefly is the pancreatectomy. This is less complex and less organs are removed compared to the Whipple's procedure. The surgery involves the removal of either the entire pancreas or only certain parts of it, such as the distal or middle sections. A total pancreatectomy is indicated for pancreatic cancer, but can have implications. For example, given that the pancreas has a role in producing insulin and glucagon, with its removal, the patient will now have pancreatogenic diabetes, which needs to be medically managed. This is important for physiotherapists to know, given that having low blood sugar levels may impact the treatment that we give to patients at a certain time. A middle pancreatectomy may be completed to remove either a small benign or cancerous tumour. However, the advantage here is that because some of the pancreas is still preserved, there are still insulin and glucagon releasing cells, and therefore there is less of a risk that the same medical consequences exist compared with the total pancreatectomy. So now we're going to transition into talking about how lung complications can arise, starting with general anaesthesia. General anaesthesia has major effects on two different systems. Firstly, it impacts the function of cilia to act as a mucociliary escalator, which reduces the amount of volume of sputum being able to be removed from the lungs. Because sputum is not being removed as efficiently out of the bronchioles, the patient starts to have a build-up of sputum within the lungs. This can eventually cause a VQ mismatch, but we'll go into further detail about this in subsequent slides. Secondly, general anaesthesia has a widespread effect on the nervous system. In particular, it reduces phrenic nerve activity, which is the nerve that directly innervates the diaphragm. If the diaphragm is not able to be expanded to its full capacity, patients aren't able to expand the chest wall adequately. Therefore, patients have less inspiratory airflow, which means less oxygen to the alveoli, causing alveolar collapse and atelectasis. As a result of less inspiratory airflow, there is less oxygen being exhaled on exhalation, or expiratory airflow pressure. This reduces the amount of shearing that air has on mucus within the bronchioles and bronchi, also reducing the amount of sputum which can be removed. Now we're going to specifically talk about the mucociliary escalator apparatus within the lung. It's comprised of a gel layer on the outside which contains mucus and is very viscous. This allows the trapping of particles coming in from the outside air. Beneath this is the sole layer, which contains mucus to help with the surface lubrication to help with beating of cilia. It is also very dependent on having enough aqueous hydration in order for the cilia to function properly, and is therefore greatly dependent on the amount of calcium to sodium ratio. The more amount of sodium in the sole layer means the more amount of mucus. However, we don't want this balance to become out of whack, because too much sodium means too much mucus, and therefore too much buildup of sputum. We want just enough sodium to calcium ratio for the mucus ciliary escalator to work effectively. Now, we know that after surgery, the sole layer becomes dried out, and therefore we get a suboptimal performing mucociliary escalator, which means that mucus isn't as effectively removed out of the lungs. Anesthesia also plays a role in down-regulating phrenic nerve activity, which is the nerve innervating the diaphragm. In normal breathing, the diaphragm acts as a bucket handle. It needs to contract to expand, and in turn expands the rib cage to allow the lungs to fill up with air. If the diaphragm cannot work effectively or efficiently, it is unable to fully expand, and as a result of this, the patient may have less bibasal expansion and poor ventilatory mechanics. This means less oxygen moving into the lungs, and in particular, less oxygen into the lower apices, into the alveoli, which can then cause low lung volumes and atelectasis. Because there is less oxygen being inhaled and therefore exhaled with exhalation, we have a reduced positive expiratory airway pressure. This reduces the amount of shearing that air has on mucus within the bronchioles and bronchi, reducing the amount of sputum which can be removed, as mentioned previously. Along with anesthesia playing a role in reducing diaphragmatic activity, the effect of being in a more supine position both during and after surgery can also affect lung mechanics and therefore overall functional residual capacity. So, what is functional residual capacity, or FRC? Well, it's the amount of air remaining in the lungs after a normal passive exhalation. FRC has shown to decrease following surgery and as a result of being in a supine position combined with receiving anesthesia. The longer the time frame of the surgery increases the effects of this. So, why is FRC important? Well, functional residual capacity, or the air remaining in the lungs after passive expiration, is needed to keep the alveoli and the small airways open. The lower the FRC, the increased chance of alveoli deflation and therefore low lung volumes. Therefore, it's imperative to get our patients into a more upright position to increase the FRC, but we'll talk about that more later. We know that there's a relationship between FRC and something called the closing capacity. Now, closing capacity is the point, or the amount of air left in the lungs after normal expiration, at which the small airways begin to close. In healthy people, this is below the point of the FRC. However, if FRC drops due to surgery and anesthesia, we have a premature closing of the airways. Therefore, less oxygen is expired with each breath, leading to reduced expiratory pressures and less shearing of mucus in the lungs. This also leads to air trapping in the lungs, meaning that over time, we also have less inspiratory air coming in, causing atelectasis. There's also implications for this in obese patients with a BMI over 30, where there are increased risks of having a reduced FRC given the increased demands of the mechanical muscles used for breathing. I'll now summarise how general anaesthesia and surgery can impact both atelectasis and sputum retention. So firstly, as discussed previously, anaesthesia has a direct impact on the functioning of the phrenic nerve. This, in combination with a supinated position during surgery and after surgery, causes suboptimal expansion of the diaphragm. Because of this, the chest wall isn't able to expand as efficiently, resulting in reduced inspiratory airflow. This reduces the amount of air going into the bases of the lungs, along with reduced inspiratory pressure. Because there's reduced inspiratory pressure going into the lungs, there's less air going into the bases, into the alveoli, causing alveoli deflation through a process called alveolar interdependence. What this means is that as soon as one alveoli becomes deflated, they sort of act as dominoes, and one becomes deflated, and then the rest start becoming deflated also. Therefore, this causes an atelectasis, or low lung volume collapse, Now, this may have functional consequences for the patient. Because of their low lung volumes, they might not be able to adequately take in as much oxygen and therefore have reduced SpO2. This may reduce their mobilization capacity. Secondly, in terms of sputum retention, because of the reduced inspiratory airway pressure coming into the lungs, there's less airway pressure moving against the bronchial walls on expiration. Therefore, because there's less expiratory airway pressure on expiration, there's reduced shearing of mucus, causing more sputum retention. There's less sputum actually coming out of the lungs or being sheared out of the lungs. Again, does this have functional consequences for our patient? Now finally, due to the combined effects of analgesia and surgery, the patient may have reduced FRC. When the patient has comorbidities such as COPD, this can also exacerbate the effects of the analgesia and surgery, further reducing FRC. Now, once FRC drops, we actually have a smaller distance between the closing capacity and FRC. Because of this, patients are unable to take as much air in with each breath because of the premature closing capacity of the small airways. Because of this reduced inhalation pressure, there is less oxygen getting to the bases of the lungs, potentially causing an atelectasis. Because of this reduced inhalation pressure and volume, there is less expiratory force on exhalation, therefore leading to reduced shearing of mucus and sputum retention. Another problem as a result of sputum retention and atelectasis may be a VQ mismatch. So, what is the VQ ratio and why is it important anyway? The ventilation rate, or V, refers to the volume of gas inhaled and exhaled from the lungs in a given time period, usually a minute. On the other hand, the perfusion, or Q, refers to the total volume of blood reaching the pulmonary capillaries in a given time period. In a post-surgical patient, there can be a mismatch between these two factors. That is, there is blood or red blood cells going to the capillary even in the collapsed part of the lung. However, although this is occurring, there is limited amount of oxygen getting there due to factors mentioned above. Think of the red blood cells like buses and oxygen like people. There may be plenty of buses going to all of the bus stops, but not enough people at the bus stop to fill the buses. So really, there's not enough oxygen getting into the bloodstream, which can cause hypoxemia, and this can be seen clinically by measuring the patient's SpO2. There are several problems which may also be presented post-surgically too. Patients are typically in a lot of pain after being operated on, and because of this, the least painful position is often lying in supine. But we know what happens when patients are in supine. Their FRC drops, and the diaphragm is placed on a less or suboptimal length tension relationship. This adds or compounds the effects of what has already happened during surgery. Secondly, patients are usually on patient-controlled analgesia or a PCA device to control their pain. While this may help them get up and mobilize, the effects of post-operative opioids or their side effects may reduce ventilatory drive, further increasing their chances for lung complications. Now we're going to talk about some of the problems that may be occurring after surgery. So the first one is pain. Now this typically isn't a physiotherapy problem because it's medically managed, but it directly affects or can directly affect the treatment that we can do with our patients. If the patient is in too much pain or if it's not adequately controlled, we won't be able to mobilize them to their highest functional capacity because pain is preventing them to do this. And we know from the literature, from the evidence, which we'll discuss later, that if we don't mobilize patients on day one, well, their risk of PPC is 3 times higher. So pain firstly needs to be controlled to optimize the way that we mobilize our patients. The second problem may be low lung volumes, which can typically be assessed using auscultation on inspiration. Sputum retention could be another problem where we hear coarse crackles on auscultations also. We can also gain a clearer picture on the amount of sputum that the patient may be retaining just by asking them if they're being able to expectorate sputum after the surgery and if this is different compared to how they were pre-surgically. VQ mismatch is another problem that we discussed earlier that patients can present with. These problems that I just discussed can affect the patient's functional mobility and their ability to discharge home. As physiotherapists, we need to optimize our patients' lungs, prevent them from attaining a post-pulmonary complication, and discharge them home earlier to reduce their length of hospital stay. A post-operative complication, or a PPC, is defined in the literature as a pulmonary abnormality that produces identifiable disease or dysfunction that is clinically significant and adversely affects the clinical course. The Melbourne Group Score defines a post-operative pulmonary complication, or PPC, of 4 of the following: abnormal breath sounds on auscultation, production of yellow or green sputum, an SpO2 of under 90% on room air, a raised temperature of greater than 38 degrees Celsius, having a chest radiograph showing collapse or consolidation, an unexplained high white cell count, and having the presence of infection or sputum on culture report. So 4 of these that I've just mentioned will mean that a patient has a post-operative pulmonary complication. So what are some of the potential repercussions of having a PPC? Well, the literature suggests that it may increase hospital stay, increase the likelihood of an ICU admission, increase hospital readmission, increase healthcare cost, and increase the chance of morbidity or mortality. This is why it's absolutely essential for us as physiotherapists to reduce the chance of a patient attaining a PPC. So now we're going to take a dive into the literature, which talks about some of the different factors that can increase the risk of a PPC. For example, Scholes and colleagues in 2009 found that the duration of surgery, that being the longer the surgery and time under anesthesia, actually increased the chances of a patient attaining a PPC. The surgical category, so having an upper abdominal surgery compared to a lower abdominal surgery, increased the risk of a PPC. Being a current smoker or having a respiratory comorbidity such as COPD also increased the risk of attaining a PPC. So now we're going to also take a further look into the literature. Parry and colleagues in 2014 showed that having a nasogastric tube in situ for greater than a day, the length of anesthesia, having an ICU post-operative admission, and the presence of cancer increased the patient's risk of a PPC. On the other hand, Haynes and colleagues in 2013 found that the time to mobilize, having an open-cut upper abdominal surgery, having an ICU post-op admission, being over 50 years old with an unscheduled surgery, or being over 80 years old with a scheduled surgery, or having a non-midline incision increased the risk of having a PPC. Hodgson and colleagues in 2015 showed that patients who were obese, which was defined as having a BMI greater than 30, also had an increased risk of attaining a PPC, which we discussed in previous slides. So now we're going to be discussing some available treatment options that we have as physiotherapists. Our first and number one treatment option is to mobilize our patients. Although sitting patients off the edge of the bed, transferring them to a chair, or getting them into a standing position with or without marching on the spot will definitely increase their FRC and optimize the length tension relationship of the diaphragm, our best treatment is to get our patients walking day one post-surgery. Now, of course, sometimes there may be barriers to doing this. For example, the patient may have a lot of pain, they might be nauseous, or their blood pressure may indicate that it's actually not safe to get them up out of bed. However, we really do need to take our patients to their maximal functional capacity when it is medically appropriate to do so. So why is mobilization so important? Well, there is a physiological rationale to why we need to do this, which we will discuss in the next slide. There's also evidence by Buland and colleagues in 2012 who found that there was a 3 times increased PPC risk for each day that patients failed to mobilize. So in this study, Buland and colleagues defined mobilizing as walking 60 meters 2 to 4 times a day at an intensity of 3 to 5 on the Borg scale. Now again, this is quite a lot for a patient to do day one post-surgery, considering the amount of pain that they may be in, which is why the best option that we have is to always take our patients to their maximal functional capacity when medically safe to do so. Now, you also have the option of adding in saline nebs. Saline nebs, which we'll discuss in later slides, focuses on increasing the amount of sodium within the sole layer of the mucociliary tract, which we discussed previously, which can help hydrate it and increase the functionality of the cilia, beating the sputum up and out of the airway. A second treatment option that we have is called the active cycle of breathing technique. This includes asking your patient to perform controlled breathing, which can help with their dyspnea or shortness of breath. And this is followed by taking large inspiratory breaths called thoracic expansion exercises, or TEE, and holding this breath for approximately 3 seconds after each maximal inhalation. This holding of the breath is termed a sustained maximal inhalation, or SMI. Now, if the patient is short of breath or has dyspnea, this may not be as practical, given that holding your breath for 3 seconds at the end of inhalation may cause them to feel more short of breath. Most guidelines suggest that patients should complete 6 TEEs with SMIs, followed by 2 forced expiratory techniques. However, this totally depends on how the patient presents and can be adjusted to what is appropriate to the patient. 2006, and Silver and colleagues in 2013 actually found that there was no prophylactic benefit for adding extra ACBT exercises in preventing the onset of a PPC. Now, we must be mindful and use our clinical reasoning in regards to this evidence. If you were to mobilize a patient a certain distance and found that they showed no clinical improvements with auscultation or were still unable to bring up sputum, there is a clear rationale to use ACBTs. Furthermore, if patients are unable to mobilize due to contraindications, it actually may be appropriate to use an ACBT technique. However, if patients aren't able to mobilize, the active cycle of breathing technique may be a useful tool to treat the patient's presenting impairments. So now we're going to talk about the pathophysiology of different patient treatments, starting with mobilization. So when the patient gets up out of bed and into a supine position, we instantly see an increased length-tension relationship of the diaphragm. This allows the chest cage or chest cavity to expand to a greater extent, allowing the lungs to fill up with more air and therefore have a larger tidal volume. When the lungs are filling up with more air, we see an increased inspiratory airflow. Because of this increased inspiratory airflow pressure, we see more air getting to the lower bases of the lungs into the alveoli. When the air reaches the alveoli, as we mentioned earlier, the alveoli actually work like dominoes. As soon as one alveoli expands, the others start to expand around it because they're connected. This process is called alveolar interdependence. Because of this, we start to see increased lung volumes. Now, being in a supine position also increases functional residual capacity. The functional residual capacity increases gradually from a sitting up in bed position, sitting off a chair, and walking. Because we have an increase in FRC, therefore, patients are able to expire more air with each breath because the small airways are taking longer to close. Because patients are allowed to expire more due to the bigger difference between the FRC and the closing capacity, we get increased amount of air pressure on exhalation, increasing the amount of mucus shearing. And just how we discussed on the previous slide, how being in a supine position increases the length tension relationship with the diaphragm, increasing tidal volume and increasing inspiratory airflow, we see more air going to the alveoli, increased alveolar interdependence, which expands the alveoli, reducing those lower lung volumes. We get an increased lung volume and FRC, and because of this, we are able to get more air behind the sputum, increased expiratory flow, which has an increased shearing effect on the bronchioles and increases the rate of sputum removal. Now we're going to talk about the pathophysiology of the active cycle of breathing technique, in particular thoracic expansion exercises. With thoracic expansion exercises, the patient takes a deep breath in with the aim to exceed normal tidal volume. This is aimed to expand the diaphragm, which increases the expansion of the ribcage and tidal volumes of the lungs increase. Due to the bigger tidal volume, the inspiratory pressure during inhalation is increased, and because of this increase in pressure, there is more air that reaches the alveoli within the lungs. When the air reaches the alveoli expand through alveolar interdependence. Another process by which this occurs is through collateral ventilation, which we will talk about a little bit more in the next slide. The aim of TEE is to increase lung volumes, which will resultantly help to move sputum due to the increased amount of air getting behind the secretions. At the top of each inhalation, you may ask the patient to hold their breath for up to 3 seconds. Again, this totally depends on how the patient presents. Patients who have dyspnea or have an increased work of breathing may struggle to do this. So it's your decision as the physiotherapist on whether you would just like them to do TEE exercises or add in the SMI. When the patient holds their breath, it is intended that there is increased transpulmonary pressure, leading to airway splinting and collateral ventilation. Collateral ventilation is the process where air travels through the channels between the alveoli, basically expanding them. Through TEE and SMI, we're increasing the positive pressure going into the airways in order to reinflate the alveoli and get more air behind the secretions. Now we're going to talk about the pathophysiology of the forced expiratory technique, or FET. This is similar to a cough. However, we don't have any forced closure of the glottis. In this way, it makes sense that there won't be as much expected pain compared with a cough, which makes it more practical and easier for the patient. So back to lung pathophysiology. The pressure within the alveoli, also known as the intra-alveolar pressure, is always higher than the outer intrapleural pressure. Otherwise, in cases like pneumothorax, the intra-alveolar and intrapleural pressures are equal, causing lung collapse. During inhalation, intra-alveolar pressure drops below that of atmospheric pressure, causing air to come into the lungs through a concentration gradient. On the other hand, with expiration, the intra-alveolar pressure increases to that greater than that of atmospheric pressure, causing the reverse to happen, where the intra-alveolar pressure exceeds that of atmospheric pressure. With FET, as air leaves the alveoli and moves towards the mouth, the pressure within the lumen of the lungs slowly starts to become equal to the intrapleural pressure, until it becomes even with intrapleural pressure, and because of this there is dynamic compression of the airways, which helps to force sputum up and out of the lungs towards the mouth. Thank you for watching this lecture on abdominal surgery, brought to you by Future Step Physios. If you have any questions, please either send us a direct message or send us an email on futurestepphysios@gmail.com. Finally, we offer one-on-one online individual tutoring sessions that are specific tailored to you. If you're interested in these, please also send us an email at futurestepphysios@gmail.com or send us a direct message. Thank you for watching.